Hello, everybody. This is Johanna Ralston of the World Obesity Federation, and welcome to our second webinar on obesity and COVID-19. Thank you very much to the many people who have joined us today. We have an excellent session, and we're going to move quickly through this beginning session because we want to hear from patient experts and global experts across the globe. So today's session is People at the Center, Obesity, COVID-19, and the Patient Perspective. And we're doing this in partnership with our colleagues from European Association for the Study of Obesity and the Obesity Society in the US, as well as members and colleagues across the globe. Quickly on housekeeping, please use the Q&A function, not the chat box, for your questions today. We welcome questions and we'll do our best to respond to them throughout the session. Those we cannot respond to today, we will respond to it at as we follow up. There will be a chance to ask questions after each speaker, so we will take probably a couple. Donna Ryan, who will be leading today's webinar, will compile questions and ask a couple, and then also hopefully at the end. Recording slides and certificate of attendance for those who require that will be circulated following the webinar today. Next slide. Here today is the agenda, Donna and myself introducing, and then we will have patient leaders from Kuwait and Europe in the next session, and then Rekha Kumar from New York, Abdullah Azari also from Kuwait, Alice Kong reporting from the Frontlines from Hong Kong, Rachel Batteram from the UK, and then Donna summarizing today's events. Here are photographs of the speakers for today's sessions. As you can see, we have a fantastic and diverse group of experts. It's now my great pleasure to turn this over to Donna Ryan, who is president of World Obesity Federation.
Thanks very much, Johanna. Let's look at the next slide. And I've chosen this slide because it puts everyone at the same starting line. So 0 here is days since 100 confirmed cases. And as everyone knows, the pandemic began in the East. So it began in China and countries around China, but this visual puts everybody at the same starting line, and it shows that the initial countries in the East were more successful in limiting the number of cases of confirmed cases of COVID-19. We've had increased cases in the U.S. and in Europe. When we gave the webinar a week ago, that we were slightly under 1 million cases, and today we're over 1.5 million confirmed cases around the world. We're talking about obesity and COVID-19, and Johanna, I think you have a few words to say about that.
Yeah, can we go to the next slide, please? So yeah, quickly, Donna published, was co-authored a piece for the journal Obesity, noting that really they're starting to observe that there's high risk for severe complications of COVID-19 for people with obesity, and certainly that's correlated at the higher levels by virtue of the increased risk of chronic disease that obesity drives, but not just that. It appears there's more going on. And also it's likely that obesity will be an independent risk factor for COVID-19, particularly if it tracks with it being an independent risk factor for influenza. There was a WHO statement issued on non-communicable diseases, cancer, cardiovascular, diabetes, chronic respiratory, and COVID-19, stating the ways in which people living with or affected by NCDs are at increased risk of COVID-19. And so we know throughout that there is also a high correlation with obesity. People with pre-existing NCDs appear to be more vulnerable to becoming severely ill with the virus. We're certainly observing that in the case of the disease of obesity. So obesity both as a risk factor and as a disease. Because obesity is not recognized as a separate independent risk factor for COVID-19, and nor is data, importantly, data in general systematically collected about BMI, we are probably missing a lot. And WAF, which is a partner to WHO, considers that this is in part because obesity is not necessarily classified as one of the 5 main diseases and risk factors within the NCD framework of WHO, and yet it sits across all of them. If we can go to the next slide, I'll just summarize what I mean. So this is a word cloud that I just sat on a call as part of a advisory group to WHO on NCDs. I'm leading a work stream on people with NCDs for the WHO Civil Society Working Group. They've started a new group around COVID and NCDs, which turns out to be a very critical factor, and are organized around the 5 main diseases and risk factors. And interestingly, obesity, and then they put together this word cloud looking at requests for help, technical assistance, and prioritization from member states, from ministers of health, and from the UN. What are the key, what are they requesting? Well, what is a word that we're seeing quite a bit here, not just in sort of up over there on the right, but it's in various other places throughout this word cloud, is the issue of obesity. So while obesity isn't explicitly recognized as a driver of COVID-19, or so, as highly correlated with COVID-19 as we believe it is, we're certainly hearing demand from countries and from the UN for help and assistance with obesity. There's also the word overweight populated throughout this. So if you look at the words obesity and overweight, you can see it all over this word cloud. And again, the size of the words reflects the kind of number of requests for information. And that in turn tells us that we need to be advocating for greater attention and resources. And of course we are, but also sharing information just as we're doing today, helping countries exchanging best practices. So that's again where the work that we and our colleagues in the obesity community are focusing our efforts over the coming weeks and months, is to really show what can be done, what is information exchange, what are best practice. So with that, I'll turn this back over to Donna.
Thank you. You know, this is really about patients. And now I'd like to call on our 2 patient representatives. First, Allison Ibrahim. And Allison, can you talk a bit about, really, I hope you'll put a face on patient concerns about obesity in the face of this pandemic.
Sure. Thank you very much. I want to thank you, Donna and Johanna, for inviting me to come on here with the World Obesity Federation. And I just wanted to say just a few things at the beginning that I'm originally American, but I've lived in Kuwait for the last 28 years. I'm a Kuwaiti citizen now, and this is my permanent home. And I just wanted to recognize and acknowledge some of the wonderful opportunities that Kuwait has afforded us as citizens and as residents here, non-citizens. And quite a few things where they shut down large gatherings and celebrations in early February, before many of us in other parts of the world were really paying a lot of attention. Lots of discussions and school closures very early, like mid-February. They instituted an 11-hour curfew in March 22nd and have now extended that curfew. They began to identify hotspots and started to cordon off some areas, and giving the people in the country more time to prepare themselves in the event that we did have to kind of sequester ourselves. A lot of messages about staying home, supermarket arrangements for ordering. And when I look at what's happening on the other side of the world where my family is, and I have 2 daughters in Los Angeles, one left New York and went to Los Angeles, and a family on the East Coast, I look at the forward thinking and the opportunity, as I said, that we've been afforded to feel a little bit more secure about the direction it's taking. Yes, we have our cases, but overall, I'm very grateful. So I just wanted to talk as a patient and really start out with like life with obesity and COVID-19. As a person affected by obesity, I have a few suggestions and positive focus that I'm living and trying to live. Nothing is consistent enough as it is in your daily life, but maybe this is some refocus that we can find a benefit in. I suggest that we follow the doctor's orders as previously prescribed unless something changes, and then you have to have a conversation about that with your medical team. keeping routines and schedules with some flexibility. Of course, you know, nobody's going to work right now. We're working from home. We're on a different type of schedule and environment with different influences, but trying to keep some of that consistency, things like keeping a mental checklist and mental check-ins. Sometimes I run through my day before I even get out of bed. What do I feel I have to do today? What is it I want to do? What's on my agenda for the day? If it's just sitting on the sofa for an hour and getting, you know, my headspace together, then yeah, that's a good thing too. So I always start out with a decrease in negativity. A few minutes of meditation, no matter how that looks for you. Everybody's idea of meditation is different. And I think taking a few minutes to get grounded, to figure out where you are and finding what to be grateful for. I also like to limit the amount of news and information that I'm getting in any big chunk. If I don't want to do it late in the evening where it's going to make me a little bit anxious about what's happening, because, you know, we're just now starting to get little snippets of some promising news. But otherwise, I want to keep present and mindful. The past is gone and the future is coming, but what is happening with me right now that I want to focus on? I like to pay attention to nutrition and my medications. As an obese person, I also, as someone with obesity, I also have diabetes and I do take medication. I feel as though planning for potential refills on medications and keeping consistent contact with my pharmacy and my physicians. I like to include exercise as much as possible now that we're out of our normal routine, but now this new lifestyle is becoming a new routine. Exercise, stretching, but rest and sleep is still very, very important. Being too keyed up and too wound up, then I get out of sync and I need a little bit more consistency for myself. So I want to focus on calm, lean into the fear and anxiety on occasion to deal with it. Listen to the experts. I think one of our experts today on the panel, Dr. Abdullah Al-Azari, has, I'm sure, wonderful information to share with us today. And find and share the positivity, motivation, and especially love. It's out there. It's out there. We're sharing it with each other. And lastly, I'd like to suggest that we want to adhere to the guidelines that we're hearing from WHO, local government guidelines, and most importantly, to stay home as much as possible. Stay in place. Thank you very much. I appreciate
Thank you,
today.
Allison.
And I'm looking forward to hearing from the other panelists.
Thank you. Thank you so much. Now let's hear from Vicki Mooney, who is the head of the European Group for Persons with Obesity. Vicki.
Thank you so much, Donna, and thank you there to Alison. I love the patient perspective that you bring and how positive you're staying in this really uncertain time. So just for myself, I'm also a patient like Alison. I'm a bariatric patient also. I've had bariatric surgery 15 years ago, and I'm the executive director of the European Coalition for People Who Live with Obesity, which are quite a new organization here in Europe. And I think the very first question that I've asked here, if you can see on the screen, is, as obesity is not widely accepted as a chronic disease, are people with obesity in the high risk category? And to elaborate a little on what Johanna had said there, you may not be in the high risk of developing COVID-19. However, you may be at higher risk for more severe symptoms and disease progression, and especially if you have severe obesity and you require intubation. And I think we're going to hear more on that. So what we're seeing is patients, these barriers they have is not getting factual information, getting misguided information, incorrect information, and being excluded from the vital information that they should get in certain countries. So unfortunately, folks aren't getting what they require. They need factual evidence-based information, and we know we don't have a lot of data. The data we're seeing is not very promising. So keep it factual, keep it clean and evidence-based. Restrictions and isolation has impacts on our comorbidities, our mental health, and hedonic eating. And physical isolation, what we're hearing from patients, from people who live with obesity, is how challenging it is mentally whilst you're physically isolated. And we all know the correlation, the links between obesity, psychological issues, the importance of psychological support, and good mental health. So being physically restricted with your family, living with obesity and various other comorbidities can be challenging. Not only that, but we're hearing very simple things like patients suffering with leg swelling from physical isolation. So you're sat at your desk all day, you're sat at home, and you're getting into these, I suppose, past or bad behaviors. We're also seeing then hedonic eating. So patients living with obesity are retreating back into probably past behaviors, comfort and binge eating, and on top of that, probably comfort and binge and drinking of alcohol as well. So these are all risks, these are all challenges and concerns. We also have, I'm not going to go into too much on this first slide, but patients who've had bariatric surgery, we know they suffer with malabsorption. Not everyone, but some, and suffer with malnourishment. So how does this affect those patients? Where are the answers for those patients? And obviously this causes stress and concern for these. We have a lot of patients who've had the cancellation of their support groups. These are their peer-to-peer groups and classes on mindfulness, cancellation of their appointments, their surgeries, and all of this creates a stress and a concern. Unfortunately, we are seeing the new wave of the stigmatizing imagery. Now, this is something that I think is going to be a challenge for us quite literally after this pandemic has passed. And what we're seeing is negative images of folks living with obesity. And these memes, you know, oh, this is what I'll look like on the beach when I come out of isolation. And we have the average folk posting these memes. And it supports that societal view that obesity is due to a lack of willpower. And this is a huge challenge. How can we inform our community of people? And I think on the next slide there, Donna, we can go into some of the resources and what we've actually done. So we have we've acquired a number of GoToMeeting licenses, which is a private, trusted online platform, so that support meetings can be done across Europe. We've offered it out to 23 countries and organizations that we collaborate with, but it can support virtual meetings for their folks that normally would have face-to-face meetings, mindfulness classes, nutrition classes. And on top of that, what we're actually seeing is a community develop on these meetings, and clinical leads, psychologists, dietitians, physiotherapists joining these meetings as well, which is reassuring for our patients. We're developing various infographics with our global partners, EASO, Obesity Canada, the OAC, and all of these infographics contain information, practical advice on maintaining health, physical activity, options for, you know, supporting yourself and your family at home, nutrition, etc. The sharing of the trusted resources from our partners around the world, which includes the World Obesity Federation, the World Health Organization, and ensuring that our patients are getting the actual information that is so important. I can't stress that enough. And we are rolling out a new community forum across Europe, which we hope will provide support for those folks who literally don't have anything perhaps in their countries, and open up a new community there. And following on from these excellent series of webinars that you've created here, we will actually develop our own, which are in the process and roll out from next week, which are more patient focused and a bit of a Q&A and factual information from our clinicians, our psychologists. We're lucky that we have a link to the EASO comms across Europe. And as COVID-19 progresses and we receive more data and information on COVID and obesity, we'll, I suppose, adapt as we go. Now, we don't have all the answers, but hopefully these resources provide some support for folks who are living with obesity, just like myself and Alison, in these very worrying times. Thank you.
Thank you. Thank you so much, Vicki and Alison. You know, I always learn from patients, and once again, I have. We want to know more about the webinars that ECPO is promoting, and we want to help promote them also. But let's move on now and hear from Rekha Kumar. Rekha is the medical director of the American Board of Obesity Medicine, and she really is in the trenches right now. So give us your lessons from the trenches, Rekha.
Sure. Thank you for having me. So I have kind of two different experiences with the start of the epidemic in New York City, where I can tell you about both. The first is about transitioning an obesity medicine practice to 100% telemedicine during the pandemic. And then I'll also talk about the redeployment of physicians, especially myself, from my outpatient obesity medicine practice to an inpatient hospitalist for COVID patients. And I'll also talk about obesity and the inpatient COVID experience. Next slide, please. So in terms of how we approach this, there was really just a matter of days between which we were told to start socially distancing 6 feet apart to when our office shut down. And we had probably 20 to 30 patients scheduled for me a day for obesity medicine and endocrinology. So we really had to make sure these patients were going to continue to get their care. So it really took our entire office, the administrators and the providers, to convert our obesity medicine practice into a telemedicine practice. We essentially converted our front desk staff and all our research staff to tech support for our patients that may not have had the ability to easily do a video visit with us. So we had our front desk staff and administrative staff working from home from their phones and their laptops, switching all of the visits into video visits, and then using our research staff to basically help each patient, call them, and make sure that they had all the access to the technology and understood how to use it. So in addition to just mobilizing our staff to make this transition, we really had to encourage patients to keep their appointments. I think in the initial days of this pandemic and the hysteria, there was a message to patients to really not obtain non-urgent medical care. And I think for some patients, obesity medicine and endocrinology fell under that umbrella initially, and there was a massive push to cancel their appointments. And despite the fact that we had transitioned to telemedicine, our volume dropped tremendously, but we knew our patients were struggling, and we have patients that need to be seen quite frequently for support and medicine adjustments, as well as for dietary and behavioral support. So the way we handled this was we really tried to, anytime we got a phone call or a cancellation, we responded with saying, we encourage you to keep your visit, switch it to a video visit. And for the patients that have done this, not only has it been helpful for continuity and support and treatment of their obesity, but we've realized that they probably need even more frequent follow-up during this time period. Usually I would see my patients for obesity medicine perhaps once every 3 months due to scheduling issues, but I'm finding that the video visit is so meaningful to them, and it's one of the few things they have in terms of obtaining medical care during this period that I will ask to make a follow-up visit with me or a nutritionist in a shorter interval than I normally would have. And I'm finding that patients are able to stay on track and that this method is working considering the situation. It would be great to be seeing my patients in person, but the fact that we can still continue with behavioral support, medical treatment, nutritional support, as well as prescribing has really been tremendous for the patients. In terms of prescribing, we have continued to prescribe anti-obesity pharmacotherapy over this period. It's easier when it's continuing a prescription, but we're also doing new patient video visits for obesity medicine over telemedicine. And this is where our prescribing habits might be altered. I think in our practice, which is a referral center, and we're comfortable initiating anti-obesity pharmacotherapy early in someone's course, I might stick to behavioral intervention for the first visit or two to create a rapport with a patient and to understand the mechanisms of their obesity better the way I would have in person. So I would be more cautious with prescribing things such as controlled substances, amphetamines, phentermine. We actually received a report from a pharmacy this morning that we can't prescribe controlled substances over electronically at this point. So there's changes being made. We're still trying to do our best with caring for our patients and sticking to protocols that we would have done in the office, but it has really required everyone in our office to do things that perhaps were not part of their initial job description. I do want to say we have a lot of physicians and dietitians using a web-based platform, which the director of our center, Dr. Luaroni, has a web-based platform to deliver obesity care. And it's really been a time that a lot of people that weren't familiar with it initially have been able to adopt it as a way to provide better care for their patients. Next slide, please. So that was my outpatient experience. That only lasted briefly when I was then redeployed in the first round of redeployments to be an inpatient COVID hospitalist at New York Presbyterian Hospital, which is really kind of the epicenter of the epicenter within Manhattan. So I want to talk about what my experience has been on the COVID wards, caring for these patients, and how obesity has affected the trajectory of these patients' clinical courses. So things we are seeing on the wards in patients with COVID are hypoxia and respiratory failure. That's the presenting symptom, and that's the reason we're admitting patients through the emergency department. We're seeing more coagulopathy. We're seeing pulmonary emboli. We're seeing DIC, and we're really seeing a lot of abnormal markers of thrombosis, really high inflammatory markers, extremely high D-dimers. And all of this is consistent with a cytokine storm or a picture of severe inflammation. And we're also seeing a lot of insulin resistance in the critically ill patients. And so what I want to say about those 4 clinical features that I've mentioned is that they're things that we already see as complications of obesity. So just take COVID out of the picture, respiratory failure, coagulopathy, insulin resistance, and inflammation are key features of the disease of obesity. So now we're basically adding this new novel complex viral syndrome on top of this in the patients with obesity, and the clinical picture is unfortunately very grave. Next slide, please. So I just want to talk about a few of the management things that we're doing on the wards and why they present a bigger challenge when we are treating patients with obesity. So common strategies that are being used include administering high flow oxygen. So that's probably one of the main interventions we're doing for several reasons. Number one, patients are hypoxic. They're not necessarily tachypnic, but they do need a lot of oxygen. And we're giving people oxygen in ways that we probably normally wouldn't on a medical floor. We would have taken people to an ICU, but because we are really trying to prolong the time toward the time that in which someone would be intubated, we're giving a lot of high flow oxygen, non-rebreather masks, in addition to nasal cannula. And the reason that this is more tricky with patients with obesity is that they often have obesity hypoventilation at baseline. So these are people that, as you all know, have O2 sats in maybe the low to mid 90s at baseline. And giving them high flow oxygen, which is the standard approach for treating COVID, can lead to a respiratory arrest in patients with obesity that have baseline oxygen saturations in the low 90s. So that's been a challenge where we may have to intubate someone with obesity sooner due to the limitations on using high flow oxygen. Another common approach, which people have done in Italy and in Wuhan, is proning patients to improve oxygenation to particular areas of the lungs. And again, this has been a real challenge because in patients with extreme obesity, we really can't prone them. So some of the common interventions that we're using that are non-invasive have not been as helpful in patients with extreme obesity. Lastly, in terms of clinical picture, there's more and more data that is coming out of Wuhan and from the United States and Italy on the thrombotic picture that's playing a role in managing patients with COVID. We're seeing a lot of pulmonary emboli, DIC, and this is requiring anticoagulation. We're prophylactically anticoagulating people whose oxygen saturations drop low unexpectedly. And what we're finding is that our patients with obesity really need sometimes even double the dosing of low molecular weight heparin. We're having to call hematology consults on the patients with obesity, which we normally wouldn't have done if we're anticoagulating patients for clots, but we're really struggling with getting the dosing right. We're seeing really high D-dimers in patients with obesity, even when they're on anticoagulation. So that has been my experience with these patients. Thank you.
Thank you. Now, just for the non-US people, PE refers to pulmonary embolus and DIC, disseminated intravascular coagulation. So these are thrombotic complications that are occurring with COVID-19 patients. So one question came in for you, Rekha, and that is, do you think that telemedicine it has an effect on the stigma that's associated with obesity?
So it's an interesting question. I actually felt that, at least on a one-on-one level, I found that some new patient interactions almost went a little better than sometimes they would in person, because I couldn't see the whole person, which I want to as a physician, but I found that the patient actually might have felt like maybe I was judging less.
Yeah. So if it has an effect, it would be a positive effect. I hope you're doing patient satisfaction surveys to try to nail that down. But let's move on. And our next speaker up is Abdullah Al-Azari. Abdullah is going to talk to us about the psychological aspects of COVID-19, certainly a major problem for our patients and their families.
Thank you, Donna. Thank you, Donna, for that introduction. I just wanted to check the mic was on. I am from Kuwait, and Alison has done a superb job presenting Kuwait's picture, and I really do want to thank her for that. I also want to thank Rika for making my life easy, because you've talked a lot about the medical complications, so that makes me going straight into the psychiatric aspects. So I really appreciate that. Today we're going to talk about how does mental health affect obesity, just bringing that up, but also how then obesity and people with mental health have issues with COVID-19, and what are we going to do about them. Next slide, please. I think one of the easiest ways to think about it is grief, or the 5 stages of grief model provides a really useful outline. I mean, our first response was denial, and then anxiety-driven anger and bargaining, and now depression. Maybe not clinical depression, but certainly grief and sorrow. No one has really been left untouched, but not all those who are touched have been impacted equally. The feeling of loss is palpable all around us, and maybe not all has suffered with death or loss of people, but loss of ordinary lives. I mean, most of us feel that we don't know how much we love these lives and how much we're taking them for granted, like even walks in the parks, etc., until they were really gone. Many people are worried about financial losses and a loss to their health. And people with obesity particularly have comorbid diseases, as we've already mentioned. Special accommodations has to be found, and there isn't really services that set up for that. And so I'm very proud to hear about WOF and ECPO providing some of these services and webinars. There are indeed challenges, and I think obese people, people with obesity are at increased risk of complications, as we just heard from Rika. and a challenge to get good care in the ICU. And you see that in other countries like Italy, who are figuring out who to survive. Next slide, please. We know that obesity and depression are highly linked, and that it's a bidirectional. So obesity is associated with higher depression and low self-esteem, and the people who are depressed have higher rates of obesity. That's in fact true for most mental health disorders as well. Next slide, please. The American Psychiatric Association did an interesting poll for over 1,000 people, and this wasn't the first one. There was quite a few polls, but this was an interesting one because it showed some detail. I think 48% of responders said they had some anxiety about getting COVID, but also 40% said they were worried about getting seriously ill or dying with COVID. And 62% said they were worried about a friend or loved one getting COVID. 36% said they were having a serious impact on their mental health with COVID as well. And to highlight this, I think if we move on to the next slide, quarantine quarantine had a significant impact on mental health in Italy, China, and other places, as well as New York right now. I mean, New York has done a wonderful job, but so has China, where they've found this out very clearly. People in New York have summed up with Headspace to do some meditation. And if you are from New York, or if you're having some mental health anxiety, then that's a really good site to think about. Just 10-minute meditations to use your day. Alison mentioned that already, and I thought I'd plug that in. But people who are self-isolating, really self-isolating, or in quarantine, if it's voluntary, it's a little bit less. It's a bit better than quarantine, mandated quarantine at least. But it's one of the highest predictors for acute stress disorder or even PTSD. You see some studies on physicians, which I work with on the Frontline, and they're having high rates of PTSD, and this is data from earlier on. There's increased risk about 4 times of PTSD in children in quarantine as well. So it's 4 times the rate, as well as boredom, frustration, a sense of isolation, and inadequate food supplies, and a lack of routine was distressing. Financial loss, stigma, rejection from others after the quarantine was ended was also a big factor. People tried to shy away. In fact, there's apps in some of the countries where it shows who was quarantined, and to let you know within 2 meters distance, just to notifies you who's close to you and was quarantined earlier. And that was the case in China anyway. If you move to the next slide, please. And so just if you are self-isolating, or if you have patients that are self-isolating, I just want to make sure that a couple of things that you recognize are really, really important. The first of all is a routine, maybe a new routine. I think as physicians, we are lucky to do telepsychiatry or telemedicine, as Rika mentioned, and I've changed my practice completely to telepsychiatry right now. We sleep, eating healthy and engaging in physical activity is so important, but so is taking care of your mental health. And one of the biggest things you can do is try to avoid the news. Maybe just watch it once or twice. I mean, I'm bombarded with news on social media as well as the TV, and so just trying to avoid those as much as possible, especially during self-isolation or quarantine. Unhelpful thoughts and unhelpful behaviors like tobacco, alcohol, or other drugs, or if we can avoid those kind of things, would be helpful. And making sure that you're staying connected. That's the biggest thing that comes out of the literature, but also when I'm speaking to patients in self-isolation or quarantine. It really is a big thing for them that they're connected, especially with older adults, which I see on a more routine basis. If you're a healthcare professionals, I think a big chunk of today's audience is, make sure that you're talking to your colleagues, your manager, other people beside you, because they truly are the people you should reach out to and connect to right now. The next slide, please. One of the things that we know is diet really can affect your mood, especially when it's subclinical depression. And this is one of the studies that says, take care of your diet. And I know people with obesity worry a lot about their diet and maybe reach out to unhelpful behaviors there, like stress eating or emotional eating. And so I just wanted to touch on that and move on to the next slide, where if people are worried about gaining weight, I see that as a risk factor. And certainly people in self-isolation, I've seen people have complained about 7-8 kilograms of weight. And so I'm very impressed. Rika mentioned that she's starting pharmacology during this time. I think definitely that's a really good thing to do. And I applaud Rika for doing that. But one of the things we use as psychiatrists or psychologists is mindful eating. One of the behaviors one of the skills where we're just contemplating what we're doing throughout, but also trying to taste every bite, every chew, chewing things about maybe 15 to 20 times. And we know that slows down people's grazing and eating behaviors or choosing unhealthy foods. So just being recognizant of what foods you're going to eat. If we move on to the next slide, please. I think just in summary, obesity is already linked to depression and poor self-esteem. People have lots of worries about dying. That leads to health anxieties. There's not a lot of literature out there, but I've seen it in clinical practice where people have called me just because they're coughing. So just a simple cough says, oh my God, I think I have COVID-19 and I don't know what to do. And I've had sessions where it's all about a single cough in a particular patient. So health anxiety goes through the roof. People buy more things, as we've seen with the panic buying, but also with disinfectants. And I think the first thing we can talk about is we know that we're going through grief, anxiety, depression, but trying to find what Alison was talking about, which is acceptance and maybe finding meaning through all of this, whether through friends or other people. And I think talking to people who are interested in your mental health, like your family doctors, but also your psychiatrists, maybe even before seeking a physician about COVID-19 who are so busy right now, are essential. And so I'll stop there, but thank you.
Yeah. Thank you, Abdullah. That was good for all of us. We have a lot of questions that have come in, especially about sleep. What I'm going to do is send the questions out to the speakers, and we'll be posting the answers online. So I'd like to move on now to Alice Kong. Alice was at the front line of the epidemic. Can you give us some lessons from being about 4 weeks ahead of the rest of the world in your experience with COVID-19?
Thank you, Donna's introduction. Hi, everybody. My name is Alice Kong from Hong Kong. I'm a clinical endocrinologist taking care of diabetes patients. I'm also an internist taking care of general medical patient admitted with infection. Next slide, please. I'm lucky to be healthy here to share with you through this electronic platform the early experience of Hong Kong to fight against COVID-19. And Hong Kong is one of the early places or cities in the world affected by COVID-19. Since January, we have the first imported case who's a non-Hong Kong resident, and then we know all Hong Kong people are very vigilant, and then we try our very best to reduce the spread of the infection, but with relaxation of the preventive measures, and then we have another wave of imported case in March. And many are imported cases who are students from overseas, like UK or US and other parts of the world, and many of them are young people. Next slide, please. So Hong Kong government actually have a very good close contact of all the people, citizens in Hong Kong. Every day, the news, we have updated information about number of cases, patients infected with COVID-19, and through this website from the Center for Health Protection, that we also have all the information. Next slide, please. So this is the most updated one. Today we have 974 cases. Hong Kong is a small place, densely populated with more than 7 million people. And we have 13 new cases diagnosed, confirmed today. And you can see from the right panel, we have brief demographic data, including the age and sex of the patients infected with COVID-19. And also in the middle, you can see the map of Hong Kong, the distribution of the confirmed cases and all those discharged cases. And I would like to draw your attention that we managed to keep a very low case fertility rate. The death rate is low, and then we managed to keep only 4 patients died of COVID-19. Next slide, please. So we have information, high degree of transparency, not only locally, we also keep in touch with the nearby cities and countries, including mainland China, Macau, and Taiwan, and all over the world. Next slide, please. And we have updated data, of course, focus Hong Kong, but also in other parts of the world. As I mentioned, we managed, despite we have like 10 to 20 cases every day, new cases, but then we managed to keep a very low number of deaths. And we only have 4 patients died of COVID-19. 3 of them are in their 70s, 80s, the elderly, and only 1 is a young man, 39-year-old, but he had comorbidities with diabetes. Next slide, please. Also, we have regular meetings with all the colleagues taking care of the COVID-19 infected patients. And the hospital I'm working, Prince of Wales Hospital, take care of about 10% of all the COVID-19 infected patients. Next slide, please. And the reason why we managed to have very good control of the very low death rate, that is kind of teamwork. We have a team of doctors. We all go in turn on voluntary basis to go to the isolation ward to take care of the COVID-19 infected patients. We have respiratory physician support also from ID, infectious disease specialists, and also we have radiologists, and then we discuss the case together and then offer the best, most optimal management to the patient. Next slide, please. And we try our very best to not only take good care of patients who are admitted because of COVID-19 infection, we also encourage our patients to stay at home. And in order to provide support for them to stay at home, we actually encouraged teleconsultation, telemedicine. And patients can have the choices to have just medication refill, or if they want to see the doctor, we can through electronic media to see patients, not only for general medical patients, but also other disciplines. And this is actually one of the example, ENT surgeon, who's my classmate, who promote the use of telemedicine through the TV, television, and encourage the patient that they can have the choices to not to travel all the way from their home to the hospital, the clinic to see doctors, but they can use electronic media to seek consultation. So next slide, please. Okay, I think I don't have the data, local data in Hong Kong to share with you about the BMI, the obesity data, diabetes data, association with COVID-19, but I would like to highlight the important message about why we can keep a low rate of infection, and prevention is really very important. And social distancing is really very important. We try our very best to achieve this social distancing. The government encourage people to keep social distancing by suspension of classes since the first case reported in Hong Kong, and people are encouraged to work from home. They are all encouraged to stay at home as far as possible, stay away from crowded places, and avoid social gathering. And they're discouraged to shake hands and also avoid meal gatherings. So next slide, please. So this will be my last slide. I want to share with you the snapshot when I, on my way back to the hospital. So most of the people stay at home, work from, home office, but as a doctor, we need to go to work, and also some people also need to go to work. And then I go by public transport. This is the minibus. I highlight to you that people are encouraged to wear masks when they go to the public transport. If you don't wear masks, the driver will stop you from entering the bus. And also, as you can see, the driver also wear the mask. And this is a rush hour when people go to work, and then there's not many people, as you can see, waiting at the side of the road, the pedestrians, but maybe too small for you to see. But most people, 99.9% of people, when they're not staying at home, they are outside, they wear masks to protect themselves and the others. So I hope this quick and sharing of the experience to control COVID-19 infection will help the world to work together. It should be a joint effort to fight against COVID-19. Thank you very much.
Thank you. Thank you ever so much. You know, here in the United States, we've only in the last week promoted the public health message from our Centers for Disease Control that people need to be wearing masks when they have to go to the supermarket or to the pharmacy. So your last slide is a great message. Now I want to turn it over to Rachel Batterham, who's going to be talking to us about special issues and resources for patients and physicians. Rachel?
Thank you so much. It's an honor to be part of this webinar, and I've already learnt so much. Can we go to my next slide, please? So I'm going to be talking about bariatric surgery and also resources that are available. But I want to start off with what's probably my key message, which was highlighted by Vicky, that people aren't getting the information they need. Communication is absolutely critical here, and it needs to be two-way. We need to find out what patients living with obesity need, and we need to provide that to them and make sure we're giving it in the correct way. Now, the UK is a little bit behind, I think, at the moment in how we're managing people living with obesity. So I just want to go through where we are now. So at the moment, staff who normally work in weight management clinics have been moved to frontline roles. Lifestyle medical weight loss programs have been stopped. Bariatric surgery programs have been put on hold. Clinical trials that people were taking part in have stopped. All face-to-face clinics have cancelled, and we are a little bit behind in terms of telemedicine. People with obesity are being advised to self-isolate, and there's a real lack of communication at the moment between providers and patients because we're busy firefighting. There's also the increased stigma for people living with obesity that's been mentioned. So I think at the moment, people in the UK living with obesity are feeling isolated, unsupported, abandoned, out of control, and most of all, I think they're feeling scared. So where do we need to get to? We need to identify staff who can support the patients that were coming to our clinics. We need to effectively communicate with them, and we need to keep patients on their pathways, be it weight management or bariatric programs. We need to do this. And we need to work with patient groups. We've already heard some incredible things that are going on, and we need helplines for our patients to contact. And we also need resources of best practice like this seminar today that we can share globally. We need to up our game in the UK and really introduce telemedicine. We need virtual support groups, patient forums. And on a positive point, we need to use this as an opportunity to transform how care is provided for the better, so that hopefully our patients will soon feel supported, listened to, and well informed. Next slide, please. So I've been asked particularly to talk about bariatric surgery and patients within the bariatric surgery program. And I've split this into the pre-surgery people. So actually the people who've been waiting for bariatric surgery, they have approval, they're attending their weight management programs, having weigh-ins. We need to keep these patients on their pathways, and we need to make sure that they are ready for surgery when we're allowed to operate again. So this means telemedicine, weight documentation, making sure for people who are doing this through insurance that the insurance companies are not going to penalise them for not attending weight management programs. And also really importantly, we need to make sure that we're sort of having consultations with people preoperatively to make sure their comorbidities are well managed. We know that there's a high level of diabetes in people, so we need to really get on top of glucose control, hypertension, and also make sure they're using their CPAP machine. And we may need to do this by networks. Not every hospital is going to be able to do this. So we need to look nationally, wider, and consider putting together networks. And then what about people who are after surgery? So again, for people after surgery, we need to keep them on their pathways. We cannot abandon them. We need to be providing nutritional, physical activity, and behavioural support that is relevant to people who are after bariatric surgery. And we really need to make sure that people continue with their multivitamins and supplements so that we're not going to cause nutritional deficiencies. There are clear pathways for bariatric surgery post-operative emergencies, and these need to be really clearly available, and patients need to know how to access this if they do develop problems related to the bariatric surgery. And there's a link here that I don't have time to go through, which basically lists at the moment the operations that are considered as emergency and those that need to be done relatively soon. So really making sure that we are supporting patients both pre-operatively and also post-operatively and keeping them on their pathways. Next slide, please. Next slide, please. Okay, so we've already heard today about some of the resources for a healthy lifestyle during physical distances, and we need to make sure that these are accessible resources, and we need to be able to signpost patients to these and to share best practice. They need to be specific to the population, so what might be relevant in Hong Kong might not be relevant in the UK, and we need to really think about what do our patients need. And also, we don't want information overload. When I went onto the internet looking to research for this talk, there are lots and lots of long papers. What people need is they need simple infographics or simple videos that they can take away information from. We need live webinars, local, national, global, and really easy online resources. But we mustn't forget the folk that don't have internet. And we also must think about language and how we're going to reach out to people who aren't that easy to reach through internet. Now, the areas we've already touched on, we need advice on nutrition, physical activity, and psychological support. And again, during this webinar, we've already heard many things to do with this. I've highlighted a few things here: mindfulness coach, physical activity. Our group put together some online videos which are freely available. And again, I'd encourage everybody to think about doing that. And again, to highlight patient groups down the bottom, we've already heard from Vicky, we really need to work with all of these people. Thank you very much.
Thank you, Rachel. We have many, many questions that we do not have time to answer. I want to be respectful of everybody's time who attended today. Let's move on to the next slide and wrap it up. We're going to put all the answers to these, to the questions that came in online. So all of the speakers will answer questions for you, and we'll put these up with our slides. The slides and the webinar itself will be available in just a couple of days, so you'll have access to them. If you go to the World Obesity Federation website, you can have access to the webinar that we did last week, and it'll be the same site for this webinar from today. Here are our final messages. We know that persons with obesity are at increased risk of complications from the COVID-19 virus. Not increased risk for infection per se, but we know that more complicated disease with COVID-19 is something that we are seeing in our patients with obesity. And so more than ever, we need obesity medicine expertise to deal with patients to produce a healthier society. We know that our patients and as well our practitioners are experiencing psychological stress, and our patients need our support for this. Resources are available for our patients and for healthcare providers. Our early experiences tell us that there's no cure for this pandemic. We need to share information with each other. We need to learn from each other and help each other to solve this global public health crisis. We need to take obesity seriously. One thing that this pandemic is teaching us is that obesity is a serious disease in and of itself, and we need to address obesity seriously. So please, everyone, learn more about the relationship between COVID-19 and obesity through these webinars. There are also a series of papers that are open access on the journal Obesity's website, and go to the Obesity Society and the EASO's website for other information. Johanna, do you have any final words?
I just want to thank all of our speakers, and I want to thank the many people who have joined us today. We're just so pleased and very, very prepared to send you responses to your many excellent questions in just a few days. So again, thank you. We will be here again next Friday on childhood obesity, and we will have speakers from again across the globe looking at childhood obesity and its impact, as well as the impact of obesity in the family on children, and some of the issues associated with lockdowns. We do have a patient portal, our colleagues do as well, Scopy Learning, which is something you can catch up on now that you're all at home, offering numerous free e-learning specific issues around obesity for HCPs. Further COVID-19 resources in association with obesity from ourselves, EASO and TOS. And again, we plan and look forward to the European and International Congress on Obesity, where these issues will again be highly profiled. Thanks everybody, stay safe, stay healthy, and we look forward to convening again next Friday, and please do welcome any further questions you have, keep them coming. It's so important that we're all sharing information and talking to one another at this critical time. Thank you.